evening, everyone. We are here once again on our very nice web series that is going on. So, I, Dr. Swati Bhayana, Associate Consultant, Pediatric Hematology, Oncology, and BMT Unit from Fortis Memorial Research Institute, Gurugram in India, invite you to this amazing webinar series where we are ourselves are learning a lot from our amazing peers sitting abroad. So I invite you all to the Innovations of Pediatric Hematology Oncology organized by our unit. And today we have a very special session on a very important topic, that is infantile medulloblastoma. So medulloblastomas are very common pediatric brain tumors, and they go in hand with the low-grade gliomas, and there's always an equivalence in the incidence and prevalences. However, having said that, when we talk about the success rate of medulloblastomas reaching up to 90%, 95%, there's always a subgroup of less than 3 years, less than 1 year, which are the infantile group. And we're always dealing with the problems in these subgroups because of various facts that Dr. Aditi, our very special guest, will be discussing with us today. So we look forward to a very amazing session from her. Dr. Aditi needs no introduction on the Indian pediatric neuro-oncology spectrum. She's an assistant manager, member of Division of Neuro-Oncology at St. Jude's, Memphis, and she has been an amazing part and amazing principal director in a lot of clinical trials, especially in neuro-oncology. When I was looking at her publications, the screens were falling short of the amazing list she has. So she's a co-principal director of the St. Jude trials, principal director of ACNS 2021, which is the NGGCT study, and institutional PI for the tapestry study, and a lot of publications, presentations, and chapters to her names. So welcome, Dr. Aditi. We are very glad to have you today.
Thank you very much. I appreciate that. Let me share my screen.
Sure. All the podium is yours now, ma'am.
Okay. Can you guys see? Okay, wait. Okay. Can you guys see my screen now?
Yes, we can.
Okay. So I'm going to keep it this way and not go to the presentation mode just because Zoom tends to misbehave. Okay. Thank you very much. Good morning. I appreciate this invitation to share what we have been doing with infant medulloblastomas at St. Jude for the last few years. As Dr. Swati just mentioned, I am the co-principal investigator of the current frontline St. Jude medulloblastoma trial for infants and young children. And the presentation I'm sharing forms the main background of that trial. And so kind of tells you the rationale of what we are doing and why we are doing it. And at the end, I'm going to kind of tell you the treatment schema, not the treatment schema, but more of the treatment stratification we're using for our trial and what we think is going to be the future of how we decide and the medulloblastoma treatment in infants and young children. Now, first things first, I want to be very careful about whom we are calling infants and whom we are calling young children. In the field of neuro-oncology, the definition varies depending on whom you're talking to. And really, the definition is underlined by the principle that, the very young children and infants have fast-growing neurodevelopment. And when we radiate the early neurodevelopmental axis so early, they tend to have very poor neurocognitive outcome in the long run. Now, what is that exact date cutoff? Nobody really knows. We don't know what that exact age is. But, in general, it is believed that under 3 years of age are infants and between 3 to 5 is young children. Now, there are trials and there are strategies where patients are sometimes considered young children up to 6, 7, 8 years old. We have kind of found this happy medium. Less than 3, we call them infants. Between 3 and 5, we call them young children. And over 5, we treat them like a regular child in terms of our treatment diagnosis. So with that caveat in mind, I'm going to talk about medulloblastoma in infants and young children. And to start with, I'll start with medulloblastoma in general. I think, as any pediatric oncologist would know, that medulloblastoma is one of the common pediatric brain tumors of the posterior fossa. It's an embryonal brain tumors and is diagnosed between 0 to 21 years age. And and it is for embryonal tumors pretty prevalent. Now, if a medulloblastoma is diagnosed in an older child, the treatment is pretty standard across the world. We go ahead and do a surgery and try to achieve what we call as gross total resection. We follow that with craniospinal irradiation. That means radiating the entire brain and entire spine. And then we follow that with adjuvant chemotherapy. Now, adjuvant chemotherapy strategies are different for different COG, St. Jude, and other things. But standardly, we use these three drugs: cisplatin, cyclophosphamide, and vincristine. For the last St. Jude trial that was published, this was the cumulative dose that we used for our older children. SJMB12, which is the next trial, which is about to be published within the next year, used actually lower dose of cyclophosphamide. Given that, with this strategy, you will see that the 5-year progression-free survival is actually pretty good. This is not depending on what kind of tumor they are, is it metastatic or not, or what kind of molecular subgroup, what kind of histological subgroup. Based on just all the medulloblastoma that was diagnosed, the progression-free survival, 5-year progression-free survival was 75.6% using this strategy. But, we have seen that when we use the same strategy, that means when we use radiation in very young children, so infants 0 to 3 years old, what we see is that the neurocognitive damage that is associated with CSI, it is seen in older children too, but in the younger developing neurodevelopmentally younger age group, the drop of the cognitive performance is significantly greater than the ones who are older. This is a paper that was published by one of our radiation oncologists. These were actually low-grade glioma patients, but they all got cranial radiation. And you can see that the 12-year-olds, when they got cranial radiation, kind of had a similar kind of neurocognitive pattern throughout. But the younger ones, the youngest group in this group was 5 years, they had significant drop in neurocognitive outcome over the years. The other important thing about this is that this damage to neurocognition does not plateau. So it's not a one-time hit and that's it. There is a subsequent fall of cognitive decline over the years, and it is about estimated to be 3.9 IQ points per year over a 5-year period. Other than that, CSI also causes endocrine deficiency, growth deficiency. Again, this is seen in older children as well, but it is much more pronounced in the younger ones who are developmentally young. So because of this, what we decided, in general, historically we decided is that, is there a strategy to either spare these patients with radiation or delay the radiation in some way? And from early 1980s to 2025, we have had several trials, several strategies that have looked into either radiation delaying or radiation sparing strategies. And this figure just kind of highlights that the radiation delaying strategies were early trials used like baby SFIF, CCG9921, CCG921, POG1, MOB protocol, extremely old trial, and then HIT-SK87 was one of the initial German trials that actually introduced the use of methotrexate in the beginning. Now, these trials, what they essentially did was they gave, if a patient was diagnosed younger than 3 years of age with medulloblastoma, they did surgery and then followed it with some form of combination chemotherapy to get them to a certain age, most commonly 3 years age or 36 months of age, and then gave them radiation. And that was the way of treating them. In stark contrast was radiation sparing strategies. And this strategy had the principle of that we are going to use chemotherapy in a way so that we don't have to give radiation to these children at all. And essentially, there were two big strategies that were used. One was from the Germans, so the HIT-SKK 2000 trial and the HIT-SKK 92 trial, where they introduced something called as intraventricular methotrexate. So along with systemic chemotherapy, patients got methotrexate directly inside their central nervous system through a Ommaya reservoir or some kind of reservoir that is placed. That was one strategy. The other strategy was giving chemotherapy at very high doses, myeloablative doses, and then rescue them with stem cells. So that was the Head Start strategy, the CCG 99703 strategy, Head Start 3 strategy, and there were several other strategies. very, very recently, we have tried two of the trials, SJYC07 and ACNS1221, have used the strategy of just using chemotherapy. And in SJYC07, there were a few patients who actually got focal RT, but basically they started using just standard chemotherapy to see if indeed these patients can be cured with these standard dose of chemotherapy, or do they really need this high dose chemotherapy with stem cell rescue or intraventricular methotrexate? And those trials are very few and they are very numbered. One is SJYC07 and ACNS1221, and I'm going to talk about them in the subsequent slides. SJIMB21 is our trial, the current and ongoing trial, and I'm going to end the talk with that trial stratification. But essentially, to remember radiation delaying and radiation sparing strategy, and what are those strategies? That are the big takeaway from this slide. Now, what we saw as upfront, what we saw first when we started doing these CSI delaying and CSI avoidance strategies in general is that the overall progression-free survival, which is claimed to be 75%, 80% in older kids with medulloblastoma that gets upfront radiation or upfront craniospinal radiation, is for infants, it is significantly lower than that. Okay, we say that it is about 30 to 50% in medulloblastoma survived without CSI, based on all the trial results that we have have tried to kind of summarize in a table form in this slide. You know, the POG1 studies, the HIT SKK97 study, regardless of what study it was, you can see that the event-free survival was somewhere between 31% to 50%. And that was kind of the ballpark. Now, there's two takeaway from these. One is that it is not as effective. So you need radiation to cure maximum of infant medulloblastoma patients. But the second and the more important takeaway from this is there is a group of patients that can be cured without radiation. The question is, who are these patients? And since the late 1990s or early 2000 till now, I think the neuro-oncology field has moved towards identifying who are these patients that can be spared radiation, really spared radiation, and who are these patients that require radiation for curative purposes. And it has been a stepwise approach over the decades and years. I'm going to just summarize it very, very shortly. The first thing that people looked at is clinical risk, right? Who are these patients? The patients who have minimal residual disease, that is, they are either gross totally resected or near totally resected, or they have no metastatic disease or a combination of both, one of them. So what we saw in general, again, for all those studies that I listed in the previous slide, I'm again listing them in this slide. You can see that the patients with gross totally resected non-metastatic disease tended to have better survival outcome in general in comparison to patients that have bulky metastatic disease at the onset of treatment. So that was a significant clinical risk factor, and that has stayed through the years. Now, what happened after that was a landmark discovery around 1980s and 1990s is we realized that medulloblastoma, which was for the longest time considered one tumor, can actually be divided into four different molecular types, four different histological types. Desmoplastic nodular, classic medulloblastoma, medulloblastoma with extensive nodularity, and large cell anaplastic. And what in general, big picture overview, what people generally saw was that patients with desmoplastic nodular and medulloblastoma with extensive nodularity, or MBENS, tended to do better with these radiation sparing strategy in comparison to patients with classic histology and large cell anaplastic histology. And again, I'm listing over here the same studies. And you can see that the desmoplastic nodular, this combines the MBENS as well, tended to have a pretty good progression-free survival, 88.9% in the HIT SKK trial, almost 78%, 67%, 78%. The lowest survival for these patients with desmoplastic nodular and MBEN histology was actually seen in our last trial, SJYC07, which was only 52.5%. So that was, but again, the key takeaway point from this slide are two, that MBEN and DN histology are likely curative by radiation sparing strategy, but hey, there is about 50% of them that don't even require intraventricular methotrexate, don't even require high dose chemotherapy and stem cell rescue. So who are these patients? who are these patients that can be cured without all these, even like strict, like extremely high dose of chemotherapy, and don't even need radiation for curative purposes. So that was the next question. And that question required an understanding, very critical understanding of the biology of the medulloblastoma, which has happened over the past 20 years. Again, 2 decades of work. I'm just showing in one slide. Medulloblastoma can be divided into 4 molecular groups: the Wnt, the sonic hedgehog, group 3, and group 4. Wnt is never seen in infancy. Less than 3 years old, at least I have never seen a single one. I have never seen a case reported. There has been very few patients who have been about late 5-year-olds and early 6-year-olds, but extremely, extremely rare, 1 or 2 patients. But in the infant age group, Wnt is not seen at all. So I'm not mentioning Wnt medulloblastoma in this talk at all. So essentially, the infants with medulloblastoma can be broadly divided into sonic hedgehog, group 3, and group 4 medulloblastomas. On the left side is your oncoprint that shows the common single nucleotide variants and copy number variants that is seen in these tumors. The important thing is that for the sonic hedgehogs, they tend to have mutations in the sonic hedgehog pathway, like the PTCH mutation, the SUFU mutation, the SMO mutation, and the GLE2 mutations. These mutations are pretty classically missing in the group 3 and group 4. The group 3 and the group 4, the group 3 tend to have a very high prevalence of MYC amplification. Group 4 and group 3 both tend to have a higher prevalence of MYC-N amplification. And other than that, rest of the stuff is all there. But the takeaway from this oncoprint is they were biologically very different, driven by different oncogenic pathways within the cell. So they were a different kind of medulloblastomas. So then the next step was to kind of look at, okay, so who are these sonic hedgehog medulloblastoma patients? And what we saw was that the patients with desmoplastic histology and medulloblastoma with extensive histology were extensively sonic hedgehog patients. They had the sonic hedgehog belong to the molecular group sonic hedgehog, 100% of them. I have not seen a patient with desmoplastic MBEN with any other molecular group. If we are seeing it, it's probably an error in the histology report. The classic histology has kind of a combination of everything. It tends to have a group 3, group 4, and very few sonic hedgehogs. And last anaplastic is primarily group 3 and have a few group 4 and a few sonic hedgehogs as well. So that is pretty much a distribution of the histology in terms of the molecular groups. Now, the way to identify these molecular groups varies across institutions and across the countries. For us, we use immunohistochemistry for the sonic hedgehogs. So we look at the histology, then we look at YAP1 and GAB1 staining. The YAP1 staining and GAB1 stainings are very positive, as is seen in the topmost column in sonic hedgehogs. In group 3, group 4, or non-Wnt, non-sonic hedgehogs, these are not positive. They are negative, classically negative, YAP1, GAB1. The last column is beta-catenin. These are only lost in the Wnt medulloblastomas, and these are present in both sonic hedgehog and non-Wnt, non-sonic hedgehog pathways. So that is the way we have been standardly classifying the molecular groups of medulloblastoma at St. Jude for the past almost a decade now. And we used it for our last SGMB12 trial. But again, the things have changed, right? We have learned more. And the most recent development in the field of medulloblastoma has been identification of methylation array-based classification of these tumors. Now, what we saw when we did the first set of experiments with methylation array profiles of medulloblastomas is that the sonic hedgehog and the group 3, group 4 are really in a spatial plot, right? In a spatial plot, it separates out significantly. So the methylation pattern on sonic hedgehog and group 3, group 4 are very, very different. Again, going with its genomic structures, we saw it that they are driven by very different molecular pathways. So it again kind of shows in the methylation plot as well that they're separated very nicely. Okay. Now, to make it more complicated, the next step was we looked at the sonic hedgehogs in more detail, and we identified that within the sonic hedgehog, there are 2 other subgroups, sonic hedgehog 1 and sonic hedgehog 2. Now, these are only infants. If you look at all the sonic hedgehogs, all over the children, like, all of the entire age group, the entire cohort of medulloblastomas, there are actually 4 sonic hedgehog types, 1, 2, 3, and 4. 4 is not seen in infancy. 1 and 2 is the most common, and there is some smattering of sonic hedgehog 3 once in a while. We would see some sonic hedgehog 3s there, especially the older infants. Closer to 3 or between 3 and 5, we see a lot of sonic hedgehog 3s actually. The sonic hedgehog 1 and 2 tends to stick to less than 3 years old. The group 3, group 4 was even more complex. They actually, in a methylation epigenomic plot, their characteristics often overlap. The group 3 are difficult to separate out from group 4. Now, some of the methylation classifiers are separating them, but in a plot like this, we always see that they're overlapping with each other. And you can see it in the plot, like the greens are the group 4 and the yellows are the group 3, and you can see this cluster in between, which kind of tends to be together. So in further granularity of the data, we could actually divide this group 3, group 4 into 8 separate subtypes. And there are some prevalences of certain of these subtypes in the infants, and I'll talk about it in a minute. But essentially, all of these subtypes are seen in infants. And there are 1, 2, 3, 4, 5, 6, 7, 8 type of subtypes. Each of them tend to have a different genomic characteristic, but that is too much of data for this presentation, and that will require a separate kind of presentation. But they do separate out in their genomic pattern as well. Not as clearly as sonic hedgehog and group 3, but there is still some overlap, but they do separate out. Sonic hedgehog 1 and 2 also have some different genomic characteristics. Sonic hedgehog 1 tend to have a lot of more SUFU mutations than sonic hedgehog 2. But so far, we have not been able to identify a method of differentiating these molecular subgroups, sonic hedgehog 1 from sonic hedgehog 2, or group 1, 2, 3, 4 to 8 in the group 3, group 4 category without a methylation profiling. So if you remember, I said that we can use immunohistochemistry to separate out the groups and the subgroups, but not so much the subgroups in case of methylation subgroups, if you will. So methylation is the only way right now to identify the molecular subgroups in medulloblastoma. Now, looking at the prevalence based on the age, as I kind of slightly alluded to, the youngest ones, the patients younger than 1 year of age, are mainly sonic hedgehogs. There are very few group 3s in this category. There are some group 3s who are actually MYC amplified group 3s, and they tend to do very poorly. As they grow older, the prevalence of sonic hedgehog goes down. There is, as you can see, between 1 to 3, there is more sonic hedgehog, some group 3, some group 4, 3 to 5, almost an equal distribution. And as I said, over 5 to 6, I have seen the blue is a couple of Wnt medullos that we have seen in our institution, but most of it is group 3, group 4, and sonic hedgehog. Now, to look at it, the molecular subgroups by age, if you look at the top 2 violin plots, the sonic hedgehog 1 and sonic hedgehog 2, the bright red and the dark red, those are again the most common subgroups in the infant population. The dotted line in between is the 3-year mark, and you can see the median age of diagnosis is way before, much younger than 3 years of age. As I said, there is a smattering of sonic hedgehog 3s over there. I have never seen a sonic hedgehog 4 in this category. Sonic hedgehog 4s are generally hypermutated, POL-E mutated medulloblastoma, seen mainly in young adults and actually adults. So very different biology again. Among the group 3 and group 4, the 1 to 8 violin plots, different colors, you can see over here, this bright yellow, fluorescent yellow color in between, the subtype 4, is the most prevalent in this age group. We see a lot of this prevalence. We also see group 1, group 2, and group 3 in this, and a smattering of other subgroups as well. But in general, in our practice, and of course in this data platform, you can see that subtype 4 is pretty common in this infant subgroup. So now that we understand that medulloblastoma in infants can be divided into sonic hedgehog and group 3 and group 4, Among sonic hedgehog, they are primarily sonic hedgehog 1 and sonic hedgehog 2. And among group 3 and group 4, they're primarily sonic hedgehog subtype 4 and some subtype 2 and subtype 3. The next question is, how are these subgroups responding to different kind of therapies, different kind of treatments? The treatments we just talked about, radiation delaying versus radiation sparing. How are these patients doing with those treatments? Now, of course, there has not been any prospective trial on this yet. There would be some prospective trials eventually, but or there have not been published prospective trials as such yet. In infant category, there has been some data on the older category, like ACNS 0331 and 2, but not in the infant category as such, not too much. So this is all retrospective. So people went back and looked at the older studies and kind of took out the tissue and defined them based on their molecular groups and subgroups and looked at their outcome again. So if you look at the CSI avoidance category, so these are our Head Start, HIT, a German study, and my SJYCO7, our SJYCO7 study, you will see the sonic hedgehogs tend to do well, okay? So if it is non-metastatic, this is a Head Start 4 data. Data is very, very recent. It was presented by the PI, Dr. Dal, last year in ISPNO. And they have about 28 sonic hedgehogs in the Head Start 4, and they're quoting a survival of 96% in non-metastatic group and about 36% in metastatic group. This is just an abstract, not published fully yet. They have so far not given us any group 3, group 4 data. The Germans with intraventricular methotrexate are quoting a 93% survival with the non-metastatic group and non-metastatic sonic hedgehog, and group 3 is limited, 36%. This 36%, take it with a grain of salt, because this 36% had only 6 patients, and some of them actually got focal RT. So it is a data, but it is not the most strong data, if you will. And it's not their fault. As I said, group 3 is rare in this population. So sonic hedgehog is much more common. Then SJYCO7, our last trial with which enrolled infant medulloblastoma, used low-intensity chemotherapy. So this is the therapy that used high-dose methotrexate, did not give any intraventricular methotrexate, did not give any high-dose chemotherapy with stem cell rescue, gave standard dose of chemotherapy. And of course, the survival was not as good. But you can see 51% of these patients still survived. And the group 3, group 4s, almost all of them relapsed. Now, in general, it is hard to find group 3, group 4 data with radiation avoidance strategies. Some of it is because the older studies allowed radiation at the discretion of physician. So we kind of lost that data somewhere, who got radiation and who did not get radiation. And also, those are, again, due to limited number of patients, it's very difficult to analyze that data to find out how most of them are doing without radiation. This is one paper that came out of Stanford in 2019 in Journal of Neuro-Oncology, which showed that the patients with high-dose chemotherapy and stem cell rescue, this is not a trial, this is a retrospective study of the institutional cases, did very well with 81% survival, which is expected. But the group 3, group 4, again, very limited number of patients, had 0% survival with high-dose chemotherapy and stem cell rescue. So what we learned from this slide in general is that sonic hedgehog MB is curable without craniospinal radiation. It is. It's a pretty high percentage. But there is no evidence that you can cure group 3, group 4 medulloblastoma without CSI. They need CSI at some point in their life. And maybe we will eventually find out a small subtype within them. But right now, there is no evidence that is showing that. Now, let's go into more granularity of data. We just talked about sonic hedgehog 1 versus sonic hedgehog 2. Can they be predictive of clinical outcome? As such, yes, it can be. So again, when they looked at, they did the post-hoc analysis, took the sonic hedgehog patients from the older studies and kind of did their subtype classification. And what they found was that the patients who got intraventricular methotrexate, both the sonic hedgehog 1 and sonic hedgehog 2 did well. They had a 70% and 83% progression-free survival. These are all non-metastatic patients. I will also tell you this, that most of these younger patients are non-metastatic. There are very few metastatic patients in this category. So I take that results as good. Head Start 4, as I said, this is a very recent data that was discussed in the last ISPNO meeting. They are quoting 100% survival in Sonic Hedgehog 1 and 90% in Sonic Hedgehog 2. Also take a caveat that these are like 10 patients in each cohort, 10, 11, 10, 11, but that is the data we have right now because there is limited number of patients. SJYCO7 that used low intensity chemotherapy. The Sonic Hedgehog 2 did 91%, got us 91% survival in this category for us. But the Sonic Hedgehog 1, 27.2%. So I will take you back to the previous slide. The Sonic Hedgehogs, the 51% survival in the Sonic Hedgehogs that we are quoting in SJYCO7 paper, almost the entire thing is coming from the Sonic Hedgehog 2 subtype. But the takeaway is the Sonic Hedgehog 2 subtypes for curing purposes does not require intraventricular methotrexate, does not require high-dose chemotherapy and stem cell rescue to get the same progression-free survival as these higher intensity regimen are given. Sonic Hedgehog 1 definitely requires it. It has a very poor survival with just systemic therapy. And we can see this in this table form. ACNS 2021 did try this strategy out in a low intensity chemo. They did the classification between MBEN and desmoplastic nodular. That trial was stopped in between due to some early relapses. But so we don't know the exact the data from that yet. But still, even in that trial, the trend was that with that low intensity chemotherapy, the Sonic Hedgehog 2s tended to do better than the Sonic Hedgehog 1s. So this forms the foundation of our latest infant medulloblastoma clinical trial that Dr. Robinson and I are leading is in St. Jude. It is called the SGIMB21 trial, and it is essentially a phase 2 trial of molecular and clinical risk-directed therapy for infants and young children with newly diagnosed medulloblastoma. We are using DNA methylation-based classification because we are using methylation subgroups in Sonic Hedgehogs to determine therapy in this patient. And as I have mentioned before, that the methylation subgroups, Sonic Hedgehog 2 and Sonic Hedgehog 1, can only be detected through methylation. There is no other way of detecting them yet. So we do DNA methylation of medulloblastoma, and we identify the molecular groups. Sonic Hedgehog group 3 or group 4. The Sonic Hedgehog are treated with non-radiation or radiation avoidance strategies. Sonic Hedgehog is further classified into Sonic Hedgehog 2 and Sonic Hedgehog 1. There is the smattering of Sonic Hedgehog 3s that I have talked about, are clubbed with the Sonic Hedgehog 1s. And the Sonic Hedgehog 2 is getting treated with lower intensity chemotherapy. These patients don't get intraventricular methotrexate. They don't get high-dose chemotherapy with stem cell rescue. They get 8 cycles of chemotherapy. And before that, 8 cycles of chemotherapy. First few cycles are with high-dose methotrexate. The last couple cycles are not with high-dose methotrexate. The Sonic Hedgehog 1, so this is our lowest intensity category patient. The Sonic Hedgehog 1, we have seen that this therapy did not work for them, at least in retrospective study. So we have gone ahead and added the intraventricular methotrexate for this patient population. So these patients, any patient other than non-Sonic Hedgehog 2 are treated in this higher Sonic Hedgehog risk category, again, without radiation. We gave essentially same systemic chemotherapy as Sonic Hedgehog 2, but we have increased the intensity by adding intraventricular methotrexate to that regimen. For the group 3, group 4, we don't have any evidence right now that these patients can be treated or can be cured without radiation. There is evidence that the disease can be very well controlled with chemotherapy, but as soon as the chemotherapy stopped, within the next months, or even during the chemotherapy sometimes, the tumor tends to come back. So for them, we are using our age-old radiation delaying strategy. We give them systemic chemotherapy till they are 36 months of age, and then give pre-relapse risk-adjusted CSI. I have not gone into the details of the trial because I cannot, but this pre-relapse risk-adjusted CSI allows us to actually give them lower doses of CSI rather than 36 gray. And we base that doses based on their response to chemotherapy. Some of the kids who get very few. So, for example, a patient was diagnosed at 34 months of age, getting only 2 courses of chemotherapy before they get 36 months of age to get radiation. Those patients are even offered carboplatin with CSI based on the ACNS 0332 data, that group 3 patients tend to do better with carboplatin and CSI. But the patients who are getting already very heavily pretreated with chemotherapy were not offering carboplatin just because of the hematologic toxicity. And that is pretty much the layout of SGIMB21 trial. We are currently enrolling patients on this. I have patients from India on this. I have patients from Pakistan on this. So we do accept international patients here and there. And in case you guys have any patient right now, I'm happy to discuss them with you. It doesn't have to come over here. I'm even happy to discuss if the patient is not even coming over here. With that, I will go into a little bit of little diversion. I've talked a lot about medulloblastoma. I started with saying that, radiation is detrimental to the neurodevelopment of a young child. And so I did not want to end my talk by saying that, oh, I'm going to give radiation to group 3s anyway. Remember all these data that we show about this neurocognitive decline, neuroendocrine decline, the growth decline. Most of this data is coming from photon therapies, and also most of this data is coming from older way of giving radiations. So we have changed the way we give radiation now. We are using IMRT, or very intense modulated designing of delivering the radiation to the brain and spine, trying our best to spare the white and the gray matter as much as possible. Having said that, what do I mean by that? So if you look at the first square, not the rectangle, the first square with a big green CTV written on it, this was in the beginning, right? In the early 1990s. This is the entire posterior fossa got a boost of radiation, a 54 gray boost of radiation. Okay. With time, in SJMB96, we have brought down that CTV margin significantly. The SJMB96 used 2 centimeter margin. The SJMB03 used 1 centimeter margin. And our last trial, SJMB12, used 0.5 centimeter margin. And what we have seen in trials is that this lowering of the margin is sparing a lot of, a high volume of posterior fossa from that high dose boost, but it is not affecting survival in the long run. So we're not getting more relapses in the areas that are not boosted. And we are using the same margin for our SJIMB21 trial. So though we are saying that we are treating these patients with radiation again, the way of we are giving radiation has changed, and that matters. So though these group 3, group 4 patients will end up getting radiation, I expect that they would not be as neurocognitively damaged as our historical population. And we are testing that in our trial as well. The other thing is, of course, photon versus proton. This data is still pretty ambiguous. We don't have clear data yet, but at least the early studies that is comparing the patients with SJMB03 and SJMB12. Just for context, MB03 used photon, and MB12, at least the later patients used proton mainly. And we're seeing at least that proton beam radiation therapy is associated with some amount of stability of the global IQ. Now, there are other concepts like, performance-based or management skill, executive functioning. All those are part of neurocognitive outcome. We are still studying them. But in general, the trend we are seeing right now is that the neurocognitive outcomes are better using proton. And again, IMB21, we are recommending use of proton therapy. All St. Jude patients are getting proton therapy. We do have collaborative sites that does not have proton facilities with them. And we offered them to bring the patients to St. Jude. But, that depends on the family a lot of times. But that is what we are recommending on IMB21. And finally, an important part of infant medulloblastoma that we often miss out when we say about the treatment of medulloblastoma, and that is the surgical aspect of it. We all are aware of posterior fossa syndrome, the posterior postoperative cerebellar mutism syndrome that is pretty commonly seen in our patient population. Infants, midline tumors, and extreme, very big tumors are kind of the risk factors for these patients. To get posterior fossa syndrome, which I'm sure all of you know is limitation of speech, ataxia, cranial nerve palsy, involuntary movements, and behavioral changes, extreme irritability. Now, we always say that this is oftentimes self-limiting, like they should spontaneously resolve, but sometimes they don't spontaneously resolve, and there could be neurocognitive and neurological sequelae for these patients. For the longest time, posterior fossa syndrome was considered a disease-specific problem. It is associated with medulloblastoma diagnosis, younger age, a midline tumor, involvement of the middle and the superior cerebral peduncles. But what we have shown recently is that the surgical experience matters. So this is a paper that was published by our neurologist in 2021, where we looked at our SJMB12 patients, okay? And we saw that about 72 patients came from a high volume center where they had a very experienced neurosurgeon who does a lot of these medulloblastoma surgeries. And about 106 of them came from a low volume center. And what we saw was the incidence of posterior fossa 1 or posterior fossa 2, with posterior fossa 1 being the most severe one, and posterior fossa 2 being the less severe one, tended to have a higher incidence in the centers where there was low volume or the surgeon was less experienced. So there is a surgical risk over here. We cannot deny it. I'm not blaming the surgeons, but this cannot be denied, right? For example, you look at the A and B columns on the figure. The B column is a case MRI changes in a patient who has posterior fossa syndrome, a PFS1 type, right? He has not regained sitting balance or speech 12 months post-op. In stark contrast is 1, or A, where the MRI of a child of near normal neurologic exam. This is my patient. This patient came out slightly ataxic, but now walking, talking, running. So there is a difference in the approach. And a lot of education needs to go into in this fact. It is not impossible to attain it. And though it requires experience, it can also be taught. So that is something that is important to be noted. Patients who have posterior fossa syndrome and then get radiation, even the older kids, tend to have a poorer neurocognitive outcome than patients who don't have posterior fossa syndrome. So when we are saying that we're not going to give radiation to patients, which is potentially curative for them to protect their neurocognition, can we do something else in addition to that? And that is doing a safe surgical resection of these patients. Finally, another thing that we talk about, but we don't talk about, is hearing loss. Radiation can cause hearing loss, but so can chemotherapy. And all the chemotherapy we talked about causes hearing loss, right? All the high-dose chemotherapy stem cell rescue patients are deaf. And that is a significant risk factor for neurocognitive outcome in the long run. So while measuring, we have done some things, like I told you, we went down on the posterior fossa boost that significantly spares the cochlear and the auditory apparatus from radiation damage, so that some of these patients don't lose all the clinically significant hearing. But there are things that we can do, right? Like we do very stringent audiology evaluation at baseline and every 2 courses of platinum. We do switch to carboplatin if there is more than psi of grade 3 hearing loss. And very early introduction of assisted devices. As soon as we identify that clinically significant hearing loss, we provide them hearing aids, cochlear hearing aids, not implants, but hearing aids, so that at least in the long run, the speech, the processing, the executive functioning are not affected, though they have lost hearing. So all these things, along with the treatment, are important things to consider when you are trying to preserve the long-term morbidity or long-term neurocognitive outcome in infants with medulloblastoma. And that is my spiel. I'm happy to answer any questions if you have. I did show you in the first slide my email address. If you don't get time today, want to email me your questions, happy to answer them as well.
Thank you so much, Dr. Aditi. That was really, really exhaustive and really amazing, because somehow we as neuro-oncologists always deal with this stratum, as in which protocol to use, which chemotherapy to use, and it's always vis-a-vis decisions between whether you use the less toxic one, HIT start versus HIT SKK, and it's always a personal decision. I totally understand. And
Mhm.
definitely, as you highlighted, it is a very important thing that through years we are actually searching who are the patients who require less chemo, who are those who require less radiation. So that is definitely a very important point to highlight. And having said that, the 96.5% outcomes of Head Start 4 is something I personally am looking forward to, because that is like a really, really good numbers on the cards. I just have few questions for you that the our amazing audience from India and abroad have
I
been.
want to be, I want
Yeah,
to caution you, Swati, that
yes,
96.4% outcome you're saying is only for sonic hedgehog patients.
yeah, agreed. And
Yeah.
non-metastatic. Yeah,
And non-metastatic. So they had total of 28 non-metastatic sonic hedgehog medulloblastomas in their group. So that 96.7% is coming from those 28 patients.
we got to choose
And
the group in which we get those amazing outcomes, right?
yes, so I mean, definitely this high dose chemotherapy stem cell SQ is working for the sonic hedgehog ones. I have, and the sonic hedgehog 2s too. I have no doubt about it. It works. But the sonic hedgehog 2 doesn't need this kind of treatment. So that is the thing that we need to remember. Again, it has to be tested in a clinical trial first. So this is just an um, what you call an academic discussion, but just so that we are aware of what numbers we are seeing.
Yeah, definitely. I totally understand the caveat that it comes with. Yes. Uh,
Yes. Okay.
so the just a few questions for you, Dr. Aditi. Um,
Hmm.
do you recommend prophylactic anti-epileptic in the face of leptomeningeal disease in medulloblastomas?
No, I have never done it. I've never
Because
done it.
we understand it's posterior fossa and we don't recommend prophylactic antiepileptics usually. But
No.
sometimes we with leptomeningeal disease and we decide case to case. That's why.
Yeah. No, I have never done it. Prophylactically, never,
Okay.
ever. And I have not seen, my mentors are Dr. Gajar and Dr. Robinson, who are the gurus of medulloblastoma. And I have never seen them do it for prophylactic anti seizure therapy. Now, what happens is a lot of our patients would come on anti seizure medications from outside institution. So what we do is we slowly wean them off.
How long do you recommend steroids in a normal medullo case or in those with spinal mets?
Again, I hardly ever use steroids in medulloblastoma cases unless it is a emergency. Like, there is a big met sitting somewhere in the spine that is causing damage. Um, so that is something that, and in that case, we give steroids, we bring the patient quickly over here, and we would do laminectomy.
Yeah.
For posterior fossa tumors, steroids won't help. You have to put a shunt in or put an EVD in to release the pressure from the brain. Very different from GBMs and other things. But quick question, a very limited use of steroids.
Okay. And do you actually recommend proton for medullo? I think you very well already highlighted that point that you do recommend proton therapy for medullo. The next question is, do you recommend checking TP53 in all cases of medullos?
Yes, I will tell you this, that the TP53 mutation is much more common in sonic hedgehog 3s.
Yeah.
Okay, so very, very rare in sonic hedgehog 1 and 2. If a sonic hedgehog has P53 mutation, it is most likely not an 1 and 2. It's most likely a sonic hedgehog 3. Um, so the younger ones, the infants, sonic hedgehog 1 and 2, I see more of these, Garland syndromes. I have seen a few BRCAs actually, who tend to have this sonic hedgehog 1 and 2. But the P53 mutations are much more common as we get older. But it's a privilege of this part of the world, right? We do testing on everybody. So I'm telling you based on my data, that is, it's probably not cost effective to do P53 on all the infants, especially the sonic hedgehog. If you're seeing a patch deletion or something and it's a desmoplastic or MBEN, it's probably not cost effective.
Yeah, and actually sitting in LMIC, we rarely have children who get the entire spectrum done. It's like
Mm-hmm.
we decide that depending on availability, depending on the cost and everything, yeah, we do decide.
Mm-hmm. Mm-hmm.
Next question is actually interesting, and I think it opens another clinical trials. Do you
Mm-hmm.
ever recommend triple intrathecals or intraventricular hydrocort with intraventricular methotrexates in high-risk medullos? Never. Even we have never done that.
No, that is leukemia therapy.
Yeah. Do the medullos of Gorlin SHH type uh, are the medullos of Gorlin SHH type, and the way they fare is driven how they are SHH type, in fact. So we usually see that the Gorlin, the SUFO, and PTH1 mutations are more seen in towards the SHH types. So yeah,
Mhm. So Garland syndrome, 100% of the time, will have a sonic hedgehog medulla. Most commonly, it's a sonic hedgehog 2. Rarely will have a sonic hedgehog 1.
yeah,
I have seen a couple of sonic hedgehog 3s. I have seen actually
okay,
a couple of sonic hedgehog 3. Now, the sonic hedgehog 2 medullas with garlands tend to do really well. I will quote 100% survival with no no high-dose chemotherapy, stem cell rescue, or intraventricular methotrexate. Sonic Hedgehog 1 are very similar to what I just said. They need a little more intensification. Sonic Hedgehog 3, extremely rare with Garland syndrome. I have seen only 2 patients, and both of them did not do well with radiation sparing strategies. They were older, but I still use radiation sparing with them because they've had Garland, and I didn't want them to get, basal nevus carcinoma in their radiation field. But they all very quickly relapsed. So I think this sensitivity to chemotherapy and not requiring radiation for treatment is very specific to Sonic Hedgehog 1 and 2.
yeah,
Sonic Hedgehog 3s don't do well. But yes, it's a very young child with Sonic Hedgehog, like a 1-year-old with Sonic Hedgehog and Garland syndrome. That child likely has a very good survival.
yeah. So even in the face of Gorlin, there's like a light at the end of the tunnel. We understand.
Mm.
The next is, do you recommend concurrent chemoradio for infant medullos when they receive the bridge RT, as and when they get?
What do you mean by bridge RT?
No, do you recommend concurrent chemoradiation? So I think you already highlighted the carboplatin part.
Yes. So this has to be so. Remember, they have gotten chemotherapy in before getting to radiation. Their marrow is very, very, especially say if it was a 2-year-old got 10 months of, or 12 months of pre-RT chemotherapy, the marrow is really bogged down. And, if you give them carboplatin with radiation, they will most likely not tolerate it. Hematologically, they won't tolerate it. So, I tend to not do that to them. But if there is a patient, say, we got only 2 courses of chemotherapy before the radiation and has widely metastatic group 3 disease, we do recommend it. I do it in my trial as well with very, very, very stringent monitoring criteria. Like if if the ANC is less than 500, we give GCSF. So that monitoring requires a lot of work because these kids get sick from low counts.
And that actually adds on to the cost as well as the benefits are, I'm not sure the benefits are that quite amazing numbers with that.
Yeah, we don't know the benefit yet, right? The problem, Swati, I think the biggest problem right now we have is the numbers, right?
Yeah.
There is, it's not that the Head Start people or the ACN 0332 people don't want to publish the group 3, group 4 data. The data is very limited. So that is the problem we are having. But, if it's a wildly metastatic group 3 medulloblastoma, got only 2 courses of chemo before, and I think the marrow will take it. I
Not,
do offer
yeah.
carboplatin just for the best chance of survival.
Okay. Are you using sodium thiosulfates in your medulla groups?
I was wondering why nobody asked this question yet.
Mhm.
No. And the reason for that is, we consider all our infant medullos as high risk patients. And, if you look at that initial paper, which was essentially a meta analysis of a lot of different types of tumors, the overall survival of this with the thiosulfate in the high risk kids were slightly lower, was significantly lower than the low risk kid. We are only giving 300 milligrams per meter square of cisplatin, much less than the COG, much less than
Hepatos.
hepatoblastomas and all that. And with our stringent screening, they are doing okay. So no, we have not introduced sodium thiosulfate yet in our infant medullos.
All right. Yeah, that is always one question which hits everyone. Yeah. I
Mhm.
just have one question that ends on the audience questions, definitely. I just have one question. What is your take on concurrent chemo with proton? Do you do that routinely as well?
So proton, yeah, radiation and chemo, we do it.
With
Not
proton as
all the
well.
time, but not only not for sonic hedgehogs or anything. Only for group 3s we are doing it.
Okay, okay. Yeah,
Yeah.
so that I think that's it. And thank you so much once again for my entire team and all of us in India. It was amazing having you here, and it was really amazing how it opens us to new arenas, and we can always mail you and discuss our medullos. We're really glad to connect with you.
Yeah, no, absolutely. I mean, you don't have to, like, all patients from India cannot come over here, but happy to talk anytime. If you have any question, just feel free to email me. I'm happy to talk to you guys.
Thank you so much, Dr. Aditi. Thank you so much. Thank you so much for being an amazing patient audience. So this takes us, we'll come back next month with another amazing seminar. Thank you so much. Good evening and good day, everyone. Bye-bye.
Bye.
Bye.
Recording stopped.